Today ACT is proud to recognise the common humanity of each New Zealander by requiring that public services be delivered based on need, not race.
David Seymour making good on ACT's long-standing policy that was helped along pre-election by this.
Auckland surgeons are now being required to consider patients' ethnicity alongside other factors when deciding who gets operated on first.
Well, it's pretty simple. Race shouldn't play any part in surgical need and determining surgical need, and that's our position.
We've got a government that is actually actively promoting racial discrimination now, and it's got to stop.
Whipped along by public commentators, some of which I can't play for you because two in particular breached broadcasting standards, and not swayed by the facts.
When it comes to who waits the longest to get on surgery wait lists, it's Māori and Pacifica.
At the moment there is clear evidence Māori, Pacific, rural and low-income communities have been discriminated against by the health system.
Now we have this.
Our government now has a need not race cabinet circular, a central direction to all government departments to use only the best statistical analysis of which people are most in need of social services.
But what if the best statistical analysis of which people are most in need of social services is using the ethnicity marker? I'm Alexia Russell, and today on The Detail, the public service circular from the Cabinet Office that prompted a group of senior public health physicians to pen an editorial against it.
It seems to be based on a false and unsubstantiated assumption that any previous ethnicity-based targeting in our health system has not been based on a robust analysis of need.
Belinda Loring was the lead author of that editorial, published in the New Zealand Medical Journal, and here she is talking about it on their Facebook post.
We've come together to speak out in response to the government's recent directive, which is imposing additional requirements on agencies who are considering targeting services to specific population groups because of the government's concern that ethnicity is being used as a proxy for need. So in our editorial, we revisit the basic scientific facts and reasons for ethnic targeting in our health system and why this practice needs to be strengthened rather than hindered, and why the government's directive threatens not just lives but wastes money.
I asked Belinda to tell me about the science behind using the data on ethnicity as a legitimate tool in healthcare when it comes to determining need. And we know the government just loves using data and evidence to back up its decisions.
How does cutting over 400 public sector science jobs across GNS Science, NIWA, Callaghan Innovation and other government departments support his coalition commitment that, quote, decisions will be based on data and evidence, end quote?
What data and evidence did he receive from officials on the impact of repealing the clean car discount on the second and third emissions budgets prior to the Cabinet decision to do so?
Now, the coalition agreements say that decisions will be based on data and evidence, and yet this decision to repeal what would have been globally leading legislation, smoke-free legislation, flies in the face of data and evidence.
It certainly feels like this directive is a particular attack on science and public health advice.
We've seen as recently as last week in Hawke's Bay, government departments using just one statistical indicator, a person's ethnic background, to decide how to allocate public services. This government is committed to a social investment model and sound use of data in all it does in order that we make sure the people who really have the greatest need are those that are getting the help.
Belinda, tell me first about your sort of qualifications in this area.
I'm a public health physician, so a medical doctor that's specialised in public health medicine, which is the area of medicine that looks at the patterns of disease in populations. So zooming out and working out at a whole of population level, who's more at risk, who's less at risk, and how do we effectively prevent and treat diseases at a population level. So it's through that expertise that I've become involved in health inequities research and epidemiology about how diseases are distributed in society.
So I'm presuming that this sort of decision-making, particularly in health, does rely quite heavily on gathered data.
Yes, so we have a duty to allocate health resources in the best way possible. We're trying to use all of the available data sources that we have at our disposal to assess constantly who's going to have the most benefit, how we minimise the risks of unintended harms to people, and how we get the most overall benefit from the health resources that we have available to us. So data is critical for that.
Now, this government says it is the government that makes decisions based on data and science. How does that gel with the edict that, Seymour uses the word race, is no longer to be part of the decision-making process?
For scientific researchers that are familiar with data in this area, that makes no scientific sense to us whatsoever. From all of our research, ethnicity is not just an evidence-based marker of health need, but consistent, overwhelming evidence tells us that ethnicity is a stronger marker of need than the other characteristics that we have at our disposal, like deprivation or age or rurality. So it would seem that it's completely contrary to showing a regard for evidence and science.
Why is it a stronger marker?
That's an interesting question. I mean, it's important to note, I guess, that firstly, it's not the ethnicity itself that leads to poor health, right? It's because racism and marginalisation are so strongly distributed along ethnic lines in New Zealand, which makes ethnicity such a strong predictor of need.
There's a notion in this country that everyone has the same shake at things. If that was the case, we wouldn't have significant socioeconomic inequities. And in the case of Māori, pretty much across every major industry we know.
But no matter where we look, we have evidence of lower Māori life expectancy, for example, higher health need, lower immunisation, lower access to health services, and poorer health outcomes. These are all evidence of ethnicity being a very strong marker of need. And for example, ethnicity is the strongest marker of avoidable death, even after adjusting for deprivation or rurality. And if we look at, for example, even those people living in high deprivation areas, Māori will have poorer outcomes than non-Māori, even in high deprivation areas.
So when Seymour says that everyone should have access to services, and, you know, I guess he's talking about things like vaccination, just general healthcare, GPs, that kind of thing, rather than being judged on what their ethnicity is, you know, I mean, that seems on the surface to be a reasonable expectation.
Absolutely. I mean, we all deserve an equal chance to be healthy and to receive the care that we need, regardless of who we are and where we live. We all deserve a health system that works equally well for us, regardless of our ethnicity. You know, wouldn't it be nice if we had a health system where all babies have the same chance of being protected from vaccine-preventable diseases, regardless of their ethnicity? Wouldn't it be nice if Māori and Pākehā shared the same likelihood of living a long life in good health, or the equal chance of receiving a GP appointment or a lab test? But, you know, the evidence that we have is that this is currently not the case. So people are not turning up to health services with equal levels of need, and they're not being treated equally, and they're certainly not receiving equal outcomes based on ethnicity. You know, I mean, if we look at our babies, at 18 months, we've got 44% of Māori babies vaccinated compared to 70% plus of Pākehā. You know, Māori with type 2 diabetes are twice as likely to die than non-Māori. That's even after adjusting for all of the other things we can think of that might make a difference, like age or smoking or obesity or deprivation. We have overwhelming evidence that Māori receive less care, even just taking primary care, for example. Māori are 2/3 as likely to receive a GP appointment than non-Māori. So each year is about 750,000 missing GP appointments for Māori, even just to receive the same level of GP access that non-Māori have, you know, notwithstanding any of the higher health need that Māori might have. I think it's important that We look at the evidence of who's actually receiving services and what outcomes people are getting. And the evidence that we're seeing is that Pākehā are not missing out. Even if, for example, you take something like COVID vaccination, we were particularly concerned as public health professionals when COVID was first hitting our shores, that because Māori have poorer health in general, known problems in accessing vaccination, that Māori would have lower vaccination coverage for COVID-19 and would therefore die more than non-Māori. And measures were introduced to try and ensure that Māori and Pacific did have access to COVID vaccination. And yet, even knowing that, even with all the scientific evidence that we had at the time, even with some extra measures to try and make sure that Māori and Pacific didn't miss out, when the Delta wave hit November 2021, at that point, only 77% of Māori had received their first vaccination compared to 94% of non-Māori, non-Pacific. So even with extra measures, it's still Māori that are missing out. Pākehā are not being disadvantaged here.
Okay, let's look at if you took out the poverty markers. What is it about someone's ethnicity that in the data shows they have less of a chance, if you like? You talk about the underlying racism. Is it that, when you turn up with a brown face there, no matter how hard you try, there are assumptions made about you?
It's a combination of a whole pathway of factors. So if you think about what leads to us being healthy or not healthy, the determinants of health, those things are not evenly distributed based on ethnicity in New Zealand. We know that things like health literacy, being able to unpack how and where and when to access services is lower in Māori than non-Māori. There's also, we've talked about higher levels of health need, but once you reach a health service, there is also evidence of unequal treatment once you get through that door. For example, Māori are 3 or 4 times more likely to report experiences of interpersonal racism, racist treatment by a health professional, for example. We have evidence that Māori are much less likely consistently to report that their health professional listened to them or answered questions in a way that they could understand. And we also have evidence that, whilst as doctors we think we treat everybody equally, if we look at it at a population level, we do find important differences in how clinical decisions are made and how treatment options perhaps are offered to Māori versus non-Māori, for example.
For most of us, our free healthcare system is something we get to lord over others. But while we've been busy showing off, it's been busy under-delivering for Māori, resulting in a life expectancy that's 7 years less than Pākehā.
It's about Māori getting less care and poorer quality care. It's that simple. Some research has been done about if you turn up in A&E with the symptoms of a heart attack and you're Māori and non-Māori, you'll get offered different treatment. The Pākehā person will be offered the more expensive and more aggressive treatment. And Māori don't always get asked if they've got health insurance and just get offered less options.
Now, what does Belinda mean by that phrase, at a population level? Here's an example. I'm part of a population, women between the ages of 45 and 69, which is the most susceptible group for breast cancer. I don't have any symptoms of breast cancer, but every 2 years I'm offered a free mammogram and off I go and get it done. Men get breast cancer too.
Initially, I had to come to terms with having a woman's disease. I know I don't want to be disrespectful to women, but as a man getting breast cancer, because you hear so much about women's breast cancer and so many women get it, it's like, why me? Why have I got breast cancer?
Greg there is one of about 25 Kiwi men diagnosed with breast cancer every year. But the disease is the biggest cause of death for New Zealand women under the age of 65. 1 woman diagnosed every 3 hours. Nearly 2 women die every day from it. Men are not offered screening.
We also only screen some women because when we look at it at a population level, if we were to screen really young women with lower risk of breast cancer, the risks of harming those women would be higher because of the risk of overdiagnoses, of unnecessary procedures, all of which, contain a small but at a population level real risk of sort of unintended harm.
I guess too, if you expand the program, you're looking at older women being seen less often, which is another byproduct.
Exactly right. And that's part of the thinking. So, for example, with the bowel cancer screening, officials looked at the evidence of who's going to have the most chance of benefiting with the minimal chance of harm and overall consequences to the system. And that's why, looking at it from a total population lens, the cutoff was set at 60 years of age. And that's very typical. The default in our system is that ethnicity and other variables don't really feature in assessing policies or programs. So we ended up with a colourblind approach to bowel cancer screening, which, using that cutoff age as 60, didn't take into account the fact that most bowel cancers in Māori occur before the age of 60, so wouldn't be detected by this national screening program. So that's one example of how a colourblind approach can be completely dangerous.
So that's interesting. So that you take out the ethnicity factor, and you're saying that because this population group has a risk factor at a younger age, by not taking that into account, you have miscalculated your screening targets.
Exactly. You've failed to take into account the fact that within the numerically dominant population, we have subpopulations that have very different characteristics as a group. And if our goal is to ensure that all people in our country have a chance at living a long, healthy life, and that we reduce the burden on our health system by identifying cancers and treating them early, then you want a bowel cancer screening program that works equally well for everybody, which is why we've ended up subsequently with an adjusted eligibility range for Māori and Pacific at age 50. We need to use all the tools that we have at our disposal to pinpoint who is going to benefit most, how we can get the most value out of our scarce health resources, what can we do to most sensitively and specifically target resources towards those most in need. And that benefits all of us. It makes no sense to remove some of those markers because it means that we will be wasting scarce health resources.
You can see why David Seymour's features on this fly well with a large section of the community, can't you? I mean, if someone stands up and says we should all be equal, and why should one person go to the doctor and they can't have access to this because they're not Māori and this person can? How do you combat that when let's face it, most of us absorb news on a surface level?
I think we all want to be treated fairly, and we all like the idea that we have a system that is fair and that will give us all an equal chance. I think the problem is that there's a misunderstanding that the current system is not equal, is not equitable, and that the good outcomes and high level of high quality service that Pākehā receive isn't the same for other ethnic groups. So it's that inequity that needs to be continually adjusted. I think what often plays out in the media is this misunderstanding about the differences between individuals and populations. For example, we often hear this individual exception, for example, someone who is Māori that doesn't have high health needs, and that's used as a justification for why any ethnic targeting is justified, for example.
So, back to David Seymour's directive.
This government's cabinet circular, issued today as part of ACT's coalition agreement, puts an end to Labor's lazy and divisive approach that put a person's race before all else.
It isn't a ban on using race as a need factor when public service agencies are making decisions. But the Minister for Red Tape Cutting wants to make sure that if there's a reason for using ethnicity data, agencies should engage responsible ministers early about why they're doing that and provide a strong analytical case for targeted investment based on empirical evidence. Belinda says the directive sends a strong message to public service officials.
So the directive, whilst it doesn't go as far as saying that there shall be no more targeting based on ethnicity, what they are doing is making it harder. So they're imposing additional requirements on agencies to consult with their ministers earlier on.
The point of the Minister and Ministry of Regulation is to have someone in government who's actually there to remove red tape and regulation, where traditionally everyone else, each term of government adds a little bit more until we all drown in red tape.
Anytime that they're thinking of targeting services to a particular population group, they need to provide robust analysis and justification for why ethnicity targeting, for example, should happen. So I think the risk is how it's understood and interpreted and implemented by these agencies. So even though the directive itself still makes it clear that targeting of services for particular ethnic groups, for example, could still be completely warranted as long as there's a justification of higher need, the risk is that officials will take this as a shorthand for no more ethnicity-based anything, which is completely the opposite of what is required.
And who in the back offices of the health service will provide the strong analysis and justification for using ethnicity data?
And we will move resources from the health bureaucracy to the frontline services.
There's certainly no indication that this directive has been informed by evidence. If the government wanted to allocate resources in the best way possible, both for the purposes of improving the health of all New Zealanders and for prudent allocation of health resources, it would be our scientific advice that they use all available data metrics to identify those most at need and to monitor performance of the health system.
That's it for today. The Detail is a newsroom production supported by RNZ and New Zealand On Air. This episode was engineered by Phil Benge and produced by Davina Zimmer and Gwen McClure. Thanks to Belinda Loring. I'm Alexia Russell. Ka kite anō.